Hello, everyone. Let me know if you can hear me. Greetings, all, whoever is present. Hello, hello. I'm going to start here in just a few moments. Stuff is on. Anyone get a chance to help out with the interviews today? It seemed like they went pretty well, at least on my end. At least I enjoyed most all of my candidates. I've lost my soda. Thank you all for joining me. I know it sounds trivial, but I love it when I get those likes. It just like gives me an extra little bit of warmth in my heart. Cold, cold, dead space where my heart would be warms up just a little bit. Even though it's totally irrational. Although it was nice during interviews today to be like, well, I'm pretty sure, I hope we get to be on campus in the summer. And it sounded like that was actually something in the near future, relatively near future. Well, I hope that happens. Of course, you know, if you got questions, put them up in the chat or in the sticky. Like I said, it wasn't even 5 a.m. yet, and he had you as his interviewer. Oh no, where was he at? I don't remember anyone that was on the West Coast. Thing. Yeah, I wouldn't want to deal with me at 5 either. Wow, Hawaii. I wonder if he's on vacation or something. That's interesting. Well, if that would be, that's like hard mode interviewing for sure. That's very funny. The little things we don't find out about until hear the scuttlebutt. Oh, the Navy. Huh? Interesting. The word of the day was tutelage. A lot of people were using the word tutelage, which I thought was interesting. It's funny, you'll find like with interviews through the years that like the common buzzwords will shift over time. So like for a while it was lateral mobility. That was a common thing we'd hear. So we almost have like a bingo card of all the most common sayings. Oh, hello. I did have someone use the word irregardless, and I almost automatically disqualified them. I know. We only have room to go up. Hopefully, you can't take away legs, because otherwise, it might be down to negative numbers by the time we finish here. They don't show me all the down thumbs, so probably a good thing. That throw me off my game. Well, that's so sweet of you guys. That's really nice. Yeah, yeah, we normally don't like think about it too long. Normally they're kind of out of our mind before the next interview happens, but you know, some people stick with you for a while. Will not share any details of it. Some people stick with me for years afterwards. I'm like, what were they thinking? But that person was really good. But anyway, let's see. I'm gonna start recording here, and back on the sticky board. I don't see any questions up here so far. Thank you all for joining me today. I appreciate it. I think this is where we left off talking about some of the different treatment modalities that we have available for managing seizures. And so, again, as I mentioned, a lot of people are managed well with just monotherapy, but you will find, especially a lot of patients who, and I see this a lot in pediatrics, we have patients that will have like either congenital issues or some sort of genetic, you know, condition that's developed where they require many drugs. And, there are some cases where you'll find patients who are on 4 or 5 medications and it still doesn't control the seizures. So it can be really difficult to manage in a lot of cases. I did want to touch on the ketogenic diet portion here just a little bit because while it's not something you would think would have a big impact on pharmacy, it actually does, more so than you might originally think. So most of you are probably familiar with keto diets, meaning the very low carbohydrate or to no carbohydrate diet. And the idea is to put you in ketosis, where your body's starting to sort of auto-metabolize itself to start to burn fat and things like that. And you form ketone bodies and other acids which form a mild metabolic acidosis. We can do the same thing for these patients who are having epilepsy too. And we do it for more difficult to treat patients who maybe are not being well managed just on pharmacotherapy. And we'll put them on these ketogenic diets, and they're very strict on how many carbohydrates they can have in a day. And so that puts them in a mild acidosis. And the goal with that is it actually helps to increase the seizure threshold. It makes it more difficult for those neurons to fire abnormally when they're in a more acidic environment. So where that comes into play with pharmacy is you got to think about, well, what kind of medications are they taking, and does that include any carbohydrates? And there can be a lot of hidden sources for carbohydrates you may not even think about. Especially with pediatrics, you run into this issue because a lot of the children cannot take solid dosage forms, so they have to require liquids and suspensions. Well, what do they put into those dosage forms in order to make them more palatable? Well, a lot of sugar. So frequently we're having to do things like modify the medications they're on to make sure that they're just on tablets that you can crush and put into water, for instance. Things like that, because we don't want to be the ones to accidentally put them out of ketosis by giving them a bunch of extra sugar that they do not need. So kind of interesting, and one of those things where you kind of have a unusual interplay between the pharmacy side of things, the medications you may be prescribing, and the other medical therapies these patients perhaps are undergoing, right? Anyway, so some of the things we're going to be looking for when we're trying to determine kind of like optimal seizure therapy for these patients, there's a lot that goes into it because unfortunately there's not like a lot of medications here that are going to be completely side effect free. I mean, no med is side effect free, but these can be particularly problematic in a lot of cases here. Kaylee's asking, could giving them a more acidic drug be helpful as well? There's not necessarily any drugs, because again, we're talking about like serum pH, and so the body has a pretty good ability to buffer itself in the serum. And so, giving a medication, you'd be hard pressed to give enough of a medication to actually make someone acidotic. There actually was a case just a couple of months ago when I was working where we're using a drug called arginine chloride, and actually the chloride portion of that drug was helping to acidify the patient that was having a metabolic alkalosis. But generally, we're not trying to acidify our patients. It's not a common sort of goal, other than through this case of using a ketogenic diet. But good question. So looking at the types of drugs we're going to be using here, again, try to figure out what the goal is. Like, are how many seizures they're having a day, or maybe in a week or a month. And what's the goal? Are we going to be able to get them down to 0? Can we help out with their quality of life? Things like that. And then drug interactions are going to be a big portion of this, because most of these are going to have some degree of drug interactions. There's going to be a lot of CYP interactions, as we're going to see. We'll talk about mechanisms and how you want to make sure that you're using complementary mechanisms and not things that are going to be multiple drugs doing the same thing, basically. And then monitoring is really important. We'll kind of along the way talk about compliance and cost and whatnot. Now, there are a lot of seizure medications, and there's a few new ones that have come out within the past couple of years. I'm not going to touch on them too much because they are not necessarily used on a day-to-day basis. I'm just covering the more common ones that you're going to be running into in your general clinical practice. If you go and you work in neurology, you'll get familiar with these other ones, but I at least want to touch on the most common ones because that's what you're most likely to see, right? With most patients, when they have the diagnosis of epilepsy established, monotherapy is going to be what you go with first line, and then you add on additional drugs if you cannot achieve sufficient control with just the one drug. And then at that point, once you have multiple failed therapies, then we can add on other things. We can start to consider non-pharmacologic therapy as well, like ketogenic diets and surgery and whatnot, right? So generally speaking, with these drugs, you want to start low and go slow. the titration time on how you're going up on these drugs is going to be very patient dependent, because as we're going to find, and this is kind of a general rule with most of these drugs here, they're trying to suppress the hyperexcitability of these neurons. And so they're depressing them. And so CNS depression, dizziness, lethargy, those are going to be common side effects for the majority of these drugs. And so that can really interfere with their day-to-day life. That can interfere with a lot of things. And so titration times depend on how they're really tolerating it, right? And again, you're doing things like keeping, seizure diaries and make sure they're documenting when they're having these things and seeing what their actual response to treatment it is. And for several of them, you're going to require therapeutic drug monitoring, right? And then we can adjust the dose based on the actual blood levels they're having. Because seizures are tough because it's one of those things where you could be giving someone seizure treatment, right? You're giving them medications to prevent a seizure. And the question is, say they go a whole month without a seizure. You're saying, well, is it because the drug was working, or is it because they wouldn't have had a seizure anyway, right? So kind of like, I don't know if you ever heard the analogy of like elephant spray. Like, I have a can of elephant spray here and it works great. Look, there are no elephants around. Well, yeah, we're in Florida too. There wouldn't be any elephants unless you're at the zoo or something, right? So it's a question of whether the drug's really working. And so in a lot of cases, we can do therapeutic drug monitoring to get levels of the drugs to even see if they're within a therapeutic range. But at least let us know, hey, if they would have had a seizure, chances are it would have been blocked by the medication here. And frequently, you want to make sure the tiger preventing rock. Yeah, I guess that would be another good analogy there. But unless you're, I guess like Carol Baskin's Tiger Preserve or something like that, it's in Florida, right? But anyway, and a lot of times we'll have patients that come in for seizures and we get their blood levels for these meds and they're zero, right? So non-compliance is a big thing you'd have to be worried about there, right? Yeah, exactly. The husband should definitely be worried. So anyway, it feels like Tiger King came out like 10 years ago and it's only like last year, so time's weird. But basically, we're going to change drug therapy based on either inefficacy. So if it does not appear like it's stopping the actual seizures from occurring, or if they develop some sort of intolerance, like due to adverse effects, or some combination of the two, right? So frequently, you may stop the medication not because it's not effective, it may be very effective, but if it's not tolerable by the patient, then it's not going to work for them, right? So anyway, and then when we're switching drugs or adding something on, you always want to consider using a different mechanism of action, because if you're using one type of mechanism that doesn't appear to be working, well, using a different drug with the same mechanism, it stands to reason would have less chance of working than if you went with a totally different mechanism, which we'll get into in just a little bit. So here's kind of the general flow of things on how we would manage these patients here. So you start off with your diagnosis here, and then you begin treatment with one sort of anti-seizure drug here. So AED, ASD, any of those acronyms basically mean the same thing. And then you can pick the drug based on the seizure type, which we'll talk about a few of those in just a little bit. You're also looking at comorbidities and the side effect profiles to see what's more preferable. And I'll give you some examples of that as we get into the individual drugs there. And then if they're seizure free, and they say yes, okay, are they having any intolerable side effects? If they are, then you may need to either consider decreasing the dose, or we may change up the drug that they're getting, right? If they are not having intolerable side effects and are getting good quality of life, then we just continue treatment there, right? At some points, you may consider getting them off of the drugs, but it just depends on the patient and sort of their history there. Otherwise, if their optimal quality of life is not being achieved, then you may need to explore some issues. Maybe there's a pharmacokinetic interaction. Maybe there's a way to deal with side effects. Who knows, right? The bigger question is if they're not seizure free, and especially if they're getting intolerable side effects, then yeah, switch them over to something else, right? You may need to consider doing things like decreasing the dose of one drug and then adding on a second drug, for instance, right? These are things to all kind of consider in terms of like, where do you go from step to step, right? And most of this should make some degree of sense to you, just from a logical standpoint. Again, if they're seizure free, then okay, keep doing what you're doing. If not, then you got to try something else. Either try to maximize the dose of the drug that they're on or add something else onto it potentially, okay? So let's get into looking at where the drugs specifically are going to be working. I'm going to talk about how we're going to be using these drugs individually. We'll talk about which ones are going to be good for sort of prevention of seizures, which ones are going to be really good for treatment and cessation of acute seizures that are happening, and kind of everything in between. The main targets we're going to be looking at are going to be various receptors up in the CNS, and this is going to, and some of these will look similar to what we saw with the antiarrhythmic drugs, which will actually have some interesting crossover here. We'll see in a moment. We have sodium channel blockers. You guys are familiar with that in terms of how those affected the heart. Remember the class 1A, B, and C drugs, right? We have calcium current inhibitors. We're going to have gamma aminobutyric acid or GABA enhancers. So some examples of that. And then some of the lesser used ones include things like drugs that block glutamate. If you recall, glutamate's that main excitatory neurotransmitter. So if you can inhibit that, that presumably would decrease the hyperexcitability and lead to less seizures. And then some other things we could do too. So if you recall, we mentioned carbonic anhydrase inhibitors in the past. And actually, Haley, you made a very good point that I didn't even address here, but here's a drug where we could actually induce a metabolic acidosis, a slight one, but one you could actually use to help enhance acidifying that patient a little bit. And so rarely we'll use things like carbonic anhydrase inhibitors. If you don't recall from last semester, we talked about one called acetazolamide. Recall, it makes you basically pee out extra bicarb by blocking reabsorption in that proximal convoluted tubule. We have some hormones we can look at. We'll actually see things like estrogen and progesterone may actually affect seizure threshold. And then we'll have some drugs that we don't really know how they work. We just seem to think that they work, and we go with that, right? It seems crazy. We have drugs we're like, I don't know how it works. It just does, and we go with that. But that's the case in a lot of situations. So anyway, let's talk about our action potential cycle that happens here with these nerves, right? These neurons in the brain. Basically, imagine you're looking just at one nerve. You're looking at the electric potential of that nerve. Notice here that it's going to be sitting at, a resting membrane potential, usually negative 70 millivolts or so. And again, that can be changed based on the pH of the patient. It can be changed based on genetic issues. A lot of different things could affect this. But basically, it receives a signal. It receives a signal that says, hey, generate an action potential. And so what's going to open up first? Well, this is going to be very similar to what we saw in the heart, where sodium channels open up first. Because remember, outside of the cell, it's a relatively high concentration of sodium, right? Our normal serum sodium is like an average of 140 milliequivalents per liter. That's a lot higher than what it is within the cells, right? Remember that salt wrapped banana analogy I like to use. Your cells are full of potassium, but there's a lot of sodium on the outside of them. So anyway, so when those open up, you're going to see the potential peak. You're going to start to see it go up because all the sodium channels are coming in. And then those sodium channels then become inactivated, just like we saw with the heart. Then at this point, how do you get the cell to go back and repolarize? Well, a lot of that is going to be due to potassium efflux. You will then open up these potassium channels. It will flow out along this concentration gradient. The potential will come back down. You'll see you get this degree of hyperpolarization. Remember, there's a period of a refractory period that you'll see with these neurons to make sure nothing else can come along and trigger another action potential. And then the sodium potassium ATPase pump will then get it back to the resting membrane potential, and then the whole cycle can start again. So presumably, if we're having a neuron that is firing too frequently, well, let's just block that whole depolarization phase in the first place and then keep it from firing. So you can use something like a sodium channel blocker in order to do that, just like we did for the heart in treating atrial and ventricular arrhythmias, right? And remember that sodium channel exists in sort of three states. There's the resting state, where it's kind of just waiting for a signal to come along. There's the active open state, and then for part of that refractory period, it goes into the inactive sort of state, where it takes a while for it to reset to go back to the resting, basically. Okay, here's an example of what this would look like, where you can see here the open channel and where different drugs can be affecting this. So here's a couple of agents that we're going to talk about specifically: phenytoin, topiramate. They will actually help to block and help to keep this in the inactivated state to prevent another action potential from occurring. So you'll see a few more pictures like this, but normally the sodium channel, we're going to try to keep it closed to prevent that depolarization from happening. Okay. With calcium channels, you're going to see there's several different types. So if you recall, see Brian's asking, are the AED sodium channel sodium blocker specific for the brain? That's a good question. I'm going to talk about that a little bit. We might see there's a little bit of crossover here in just a little bit, but good question. In terms of calcium channels, you're going to see in the human brain, there's L, N, and T types. If you recall that I believe it was the L type that we mainly saw in the cardiovascular system, but the T type calcium channels are actually what we're going to be using specifically. And again, most of our antiepileptic drugs work sort of broad spectrum. They're going to work on a lot of different types of seizures. Here's an example where we find that people who have absence seizures are particularly due to these T-type calcium channels. And by blocking that, we can actually have a very good treatment for absence seizures, right? I've actually been known to be a big cause for absence seizures. Most of the time I'm lecturing, especially when it's in person, everyone goes into like a 2-hour like fugue state. And then as soon as I'm done, everyone wakes back up. It's pretty interesting. But we'll see that there's some drugs that work specifically for that. And I'll give you an example of that, ethosuximide, a little bit later on. Some of you might be in a fugue state right now, and an absence seizure, right? I know those two things are different, but that's what it seems like. Here's a picture of what this would look like. You can see how by using different medications, you can basically block and keep calcium from coming in, at least to not such a great degree as you would see in the unblocked sort of channel there. Okay. Next, we have GABA. GABA is going to be really important here, and this is going to be like if you're having an active seizure, this is like our go-to neurotransmitter we're going to be trying to enhance here. Okay. There's two main types of GABA receptors, GABA A and GABA B. Okay. GABA A is going to be the primary one we're talking about today. GABA B is going to be really important for a set of drugs called skeletal muscle relaxants. So if you think like baclofen and cyclobenzaprine and Flexeril, things like that, we're going to talk about that at a later date, probably in the ortho section when we get into pain management. But GABA B I'm not going to focus on today, but GABA A is certainly going to be really important here. GABA is really interesting because when it binds to a GABA channel, it allows it to open up and actually causes chloride to flow in. So before we were looking at drugs that block sodium or block calcium, now we're actually trying to allow a channel to open or cause a channel to open to let more chloride in. Now, what does that do for us? Well, it causes basically the electric potential of that neuron to become even more negative. By making it more negative, it makes it more difficult to have an action potential and keeps it in a resting state, basically, right? So again, that's why you're going to see a lot of sedation associated with GABA active drugs because they're just depressing those neurons and keeping them from firing, right? So I'll show you some examples of that in a moment here. As I mentioned, GABA B are actually related to some potassium channels. We'll get into those when we talk about muscle relaxants at a later date. Okay. There's different ways we can affect GABA. So, for instance, there's one way we can actually increase the amount of GABA actually being formed. And so there's something called glutamic acid decarboxylase, or GAD. Glutamic acid is just another name for glutamate, right? And so this is actually the enzyme that converts glutamate over into GABA. And so this allows it to be more GABA available to be released and interact with those postsynaptic neurons, right? So that way they can cause them to be hyperpolarized, right? Other ways we could do this includes blocking the reuptake of GABA. So instead of having, and again, usually the brain tries to be pretty economical with its neurotransmitters and tries to recycle them by releasing them into a synapse and then sucking them back up into the presynaptic neuron so that way they can be repackaged and sent out again. Well, we can block that in some cases, and that way it keeps more GABA out into the synapse and keeps it more active for longer. So that's one way we could do things. One way we could do it is to block the metabolism of GABA. So there's a enzyme called GABA transaminase, which if we block the activity of that, then it would presumably lead to higher concentrations of GABA that's available and let's interact with those neurons. And then this is a really important bit here is there's going to be sites that are located on the GABA channel itself, and I'll show you a picture of this in a moment, that when activated will allow it to be easier for it to open. Okay, so basically it facilitates the ability for GABA to work better. And it binds to what we call an allosteric site. That just means that it binds to somewhere else on the receptor than where specifically GABA binds. And this is where we're going to get into our barbiturates, like phenobarbital, and then our benzodiazepines. So here's what this looks like. So imagine a synaptic junction. Here's our presynaptic neuron here. Here's our postsynaptic neuron. And here's our GABA channel. When open, allows for chloride to flow through, okay? So, and we're going to see a lot of pictures like this when we get into talking about like serotonin and dopamine and all kinds of other neurotransmitters. So a lot of this is going to, you'll see this happening. So anyway, so the first thing we're going to see is that GABA is normally contained in these little vesicles, just waiting to be released. We'll get some signal that says, hey, release this into the synapse. It then gets released, will bind to our GABA binding sites, and then allow for the channel to open, chloride flows in, cells hyperpolarize. That GABA can then be reuptaken into the cell to be repackaged to then be released again, okay? So as I mentioned, there's a way we can block this transporter that keeps more of the GABA out here in the synapse. That's one way to increase levels of it. We could do things like blocking the metabolism. So, for instance, GABA transaminase and prevent that from working. Thus, more GABA is available to be released. And then the really important one, the one you're going to see most frequently likely, are going to be these allosteric binding sites where other drugs can bind to these receptors here. And it allows for either the channel to open on its own or it helps GABA to work more effectively, right? So that way the GABA that's there is going to kind of be supercharged to allow for those channels to open, more chloride flows in, it's more hyperpolarized. So we're getting to our benzos, which we're going to talk about pretty at length here and elsewhere in the course as well. Okay, for glutamate, in terms of those targets we could use for seizure medications here, we're going to see that glutamate, as I mentioned, is excitatory. So by blocking those receptors, you can then decrease excitability. That's one way you can do things. Turns out there's a lot of different glutamate receptors that are out there, and they all kind of do a little bit of different stuff. I'm not going to get super in the weeds on this thing, on this topic, but just know that by blocking glutamate, you can decrease some of the hyperexcitability of these neurons and hopefully reduce seizure activity. We'll see a few antiepileptic drugs that do this, but there's a lot of other types of drugs that are out there that have completely different effects, right? So while one of the activating or blocking one of these receptors may lead to anti-seizure activity by blocking others. So for instance, like the NMDA receptor, by blocking that, the drug ketamine is able to induce a dissociative anesthesia. So that way patients can have, can go basically have a out-of-body experience where you can reduce their fractures or put a joint back into place without the patient experiencing really any of that pain associated with it. So glutamate is really kind of wild in terms of the varied effects it can have, and we'll talk about some other examples of that later on. Glutamate and ketamine specifically is a pretty cool drug. We'll get into a lot of details on later on. It's got a bit of a sketchy past, but there's a lot of cool uses for it nowadays. Big fan of the Special K. Not for personal use, of course, but from a clinical standpoint. So we'll see there's a couple places where these can work. So for instance, like, AMPA kinase receptors, topiramate or Topamax is going to work here. We'll get into some more of the details on this a little bit later on with some of the specific drugs. So just be aware glutamate is used sometimes, but it's not probably the most common means of blocking the activity of or trying to prevent seizures in a lot of cases here. There's just different activities of the channels here. I'm not going to get too much into the weeds on this in terms of like what did the specific different types of glutamate receptors do. I just want you to know that if you block glutamate, overall you're blocking excitability, and that can help to prevent a seizure. For the other channels, I want you to know what they're doing. So like, why does blocking sodium channels decrease seizure activity? Why does activating more GABA channels decrease seizure activity? That kind of stuff you should be familiar with. Okay. Another question. Ooh, I had a couple questions here. So someone's saying, will drugs that bind to the allosteric site help potentiate other drugs that work in other mechanisms? Yeah, you can actually see a lot of synergy here. So for instance, if I had a drug that was enhancing the ability for GABA to bind and open those channels, like a benzo, I could then have another drug that's maybe blocking the metabolism of GABA to work even better. So yeah, we'll talk about synergy here in just a little bit when we get into the specific drugs. That's a really good question. Someone's saying, I'm a little confused about the mechanism of GABA. If GABA binding to its receptor causes increased resistance to reach an action potential, wouldn't we want more of this versus blocking it like these mechanisms suggest? I would just be super confused about the mechanism here or the action potential in a seizure. If so, sorry about that. Don't be sorry about that. It's okay. So when we're talking about this, the past couple receptor types, we've been talking about blocking those channels, like blocking sodium, blocking calcium, decreases hyperexcitability. Here, we want more GABA activity. So by a benzo binding to this site, it makes GABA's job easier and allows for that channel to open more easily. Okay. And again, when we talk about the clinical effects of these drugs, it'll make a lot more sense, and I'll actually give you some real world examples that maybe some of you have experienced at some point in your life with drugs that work very similar to this. We'll get into ethanol and how that is going to be working here in just a little bit. Good question though. Even if I didn't cover that or clear that up. Anyway, we'll see the hormones can be have some activity, even though this will not be like a go-to therapy necessarily. But you can actually find that patients who are taking, for instance, oral contraceptives that contain both estrogen and progesterone may have effects on their seizure activity. Estrogen and progesterone products are kind of interesting because just like for migraines, for instance, for some people they worsen their migraines, for some people they help, and for some people their seizures get better, sometimes they get worse. It's kind of very patient dependent in terms of how they're going to respond. And if you look at the list of contraceptives and different varieties that are out there, it is quite there are multitudes, and so I will show you some of that when we get into the OB-GYN section a little bit later on. And then as we were mentioning the carbonic anhydrase inhibitors, this is actually like really old school way of treating seizures. We don't do this much anymore, but occasionally you may see this where someone's on acetazolamide that puts them into a more acidic pH in terms of their serum, and that can increase the seizure threshold. But again, not a go-to set of drugs there. So there are over 20 anti-epileptic drugs that are available in the US. We're not going to cover every single one of them, just the really common ones you're going to run into. And it's really difficult to do studies with these drugs. There's not a lot of head-to-head to say, okay, well, let's do phenytoin versus carbamazepine, see which one does better. It's hard to do studies like that as well, and it's hard to do placebo-controlled studies because then you're letting your patient just have seizures without any active treatment. It's not a great thing. So frequently how they're studied is as add-on therapy. So that means a lot of the newer drugs coming out aren't really given as monotherapy as frequently. They're typically add-on to other stuff. So that's why I want to start with the common things, the things you're going to see used for monotherapy most frequently. And then again, if you do like a neurology rotation or if you work in neurology, you're going to get way into the weeds on that stuff and you'll know probably more about it than I ever will, depending on the case. So generally you're going to find the selection of drugs is going to be really dependent on the patient, on the provider, and you'll see things will actually change over time. And I'll give you some examples of that as we come out with some of the newer drugs that may have better safety profiles than some of the older ones. Okay. So starting out, let's get into the specific drugs. That's enough preamble, talk to death, all the background information. Let's get into the drugs. First off, you have phenytoin or Dilantin. This is actually the first sodium channel blocker we're looking at here. And so to speak to Brian's question, someone said, well, are the AED sodium channel blockers specific for the brain? Not necessarily. Phenytoin back in the day was originally studied as an antiarrhythmic drug. So the sodium channels in the heart do somewhat resemble the sodium channels in the brain. There's some cross activity there depending on the substance that you're dealing with. And this is a case where you could have a little bit of cross reactivity to some degree. Now, phenytoin is very interesting from a pharmacokinetic standpoint, but it also makes it a little bit unwieldy to use when dealing with actual patients. So again, mechanism's pretty straightforward, block sodium channels. Where it gets more hairy is going to be when you're dealing with the kinetics in terms of its protein binding. Now, looking at this, phenytoin is about 90% protein bound. That means 10% of it's available to interact with the neurons up in the brain, right? You're going to see, and that's bound to albumin. You're going to find that patients have altered levels of albumin are going to have a higher free fraction, right? So even if you went from, say, 10% free to 15% free, even though the patient's dose hasn't changed, nothing else has changed except for the amount of albumin they have, that's now a 50% increase in the amount of free drug available. That can lead to some significant side effects. So we'll talk about how we can monitor for that in just a few moments here. But the high protein binding, about 90% bound to albumin. Okay? It also undergoes something really kind of wild called Michaelis-Menten kinetics. And I'll give you a clinical example of why this matters. So if you recall, back in the summer, many moons ago, we talked about the idea of zero order versus first order kinetics, where if you recall, first order kinetics are what most drugs are going to follow. It means that if you have a higher concentration, you're going to have a higher amount of that drug being metabolized because it's always the same fraction. It's always the same 10%, 15%, whatever it happens to be per period of time, per hour, whatever happens to want to term it. With the zero order kinetics, it's always the same amount of drug constantly per amount of time. That does not change no matter how much is in the system. Drugs undergo this Michaelis-Menten kinetics, and you're like, well, what does it matter? Well, if the levels are high enough, it's possible to saturate the enzymes in the liver where they switch from a first order kinetics into a zero order kinetics. What does that mean for the patient? Well, it means that now all of a sudden it takes a lot longer to metabolize that drug off, and that can mean that they can experience really high levels and develop toxicity. So I'll give you an example. I had a patient who comes into the ER who was not compliant with their medications and they're coming in for seizure, right? Coming via EMS for seizure. We get them, they get stabilized, they're having a seizure, and the resident who's taking care of the patient ordered, say, 1 gram of phenytoin IV now, okay? So, and this was right about like 6:45-ish or so in the morning. And so the nurse came along and said, and this is, still on paper records and whatnot, so not to age myself, but it was paper documentation. And the nurse went ahead and gave the 1 gram of phenytoin to the patient, and she was, feeling fine. It was a normal drug, so she's pretty used to it. And then change of shift happens. Not familiar, 7 o'clock, 7 a.m. and 7 p.m. are generally shift change in the hospitals, at least for nursing staff. And so the nurse that was outgoing never communicated to the incoming nurse, or at least never documented it. The patient received the dose. So what happens? Oncoming nurse goes in, sees the order for 1 gram of phenytoin. She says, okay, I'm going to go ahead and make this up, and gives it to the patient. So now they've now gotten a 2 times overdose of the drug that they should be receiving. All of a sudden, the patient's like, whoa, I am super dizzy. Everything is spinning. Because again, her neurons are now being like super suppressed because they have all this extra sodium channels being blocked because there's so much phenytoin on board. And the problem is, you can't metabolize it normally because you just saturate all those liver enzymes. And so now what would normally take, say, takes like a day or so to metabolize most of the drug out of the system, now it's going to take like a week. So we ended up having to now take that patient who could have been discharged, admit them, and they're on the floor for at least, I think, 3 or 4 days just to get levels to come down to go switch from that 0 order kinetics back to 1st order in order for her to start metabolizing it normally again, right? So it's an extra admission. It's a major medical error that happened there. And then the whole time, the patient's a huge fall risk, right? Because if they start to stand up, they're going to get super dizzy and fall over and hurt themselves. So it's a big problem, right? So these kinetics, while they seem esoteric to you now, they can come up and actually have clinical impacts on you in the future with your practice, right? So there's that. Note the phenytoin itself is mainly metabolized by CYP2C9 and 2C19, so there could be some interactions that can prevent its metabolism or induce it. But the other big thing here too is that it induces 3A4 and 2C enzymes. So if someone's on a 3A4 medication, say for instance they're taking simvastatin for their cholesterol, all of a sudden they have phenytoin on board. Now those 3A4 enzymes are now elevated, which means they're going to start to metabolize simvastatin more quickly. Now maybe their lipids are not under control anymore because the simvastatin is not working as well because it gets metabolized so quickly, right? So you can run into these issues. So anytime you're messing, especially with, you should do interaction checks anyway, anytime you're doing new drugs, but especially with drugs like antiepileptics, you always want to make sure that if they're adding something onto their profile, that it's not going to be a major interaction here that could be leading to therapeutic failure of other drugs in some cases there, right? So I'm not going to get too much into the absorption and how that kind of differs with dosage forms, but and it's very broad spectrum. You can use it for almost any type of seizure, generally not absence. I will tell you in just a few moments what the treatment of choice for absence seizure is. Someone said, does that mean it increases its own metabolism if it induces the 2Cs? Yeah, to some degree. That's why, again, you're going to be monitoring blood levels for the drug over time to make sure they get to a steady level there. I will tell you there's another drug that undergoes what we call autoinduction that's a little bit more clinically significant. I'll show you that in just a moment here. So kind of keep that in the back of your mind. So along with that dizziness I mentioned, lethargy, blurred vision, a lot of nystagmus you can induce with these patients due to phenytoin, especially if the levels are too high. Some other issues that can pop up that don't really seem to be tied to its mechanism include things like hirsutism, right? May not be great for especially female patients who do not want extra hair growth. I could probably do some hirsutism myself. I'm support growing my own facial hair, but neither here nor there. You can have things like gingival hyperplasia. So like good oral hygiene is really important to make sure the gums are not going to start to kind of overgrow the teeth and make sure they're getting good dental care and things like that. And then especially for older patients who may be on this, you want to look for vitamin D deficiencies and worry about things like osteomalacia. So if they're at risk for osteoporosis, this may be accelerated in those patients there. Again, given the current pandemic, I'm sure there's a lot more vitamin D deficiencies. People are not outside as much anymore than there were before. So again, sometimes the current goings on in the world could influence some of these other kind of concomitant issues these patients are running into. So there's that. And for a long time, this was kind of like the go-to drug. It was considered to be first-line agent for most seizure types. However, because of the side effect profile, we're going to see it's not really the ideal candidate here. We may start to look for other drugs that have more favorable side effect profiles. Okay, so again, this is one of those things that's been changing over time. Now, rash and Stevens-Johnson syndrome is going to be something we're going to talk about pretty frequently. I have a whole section on that a little bit later on here. But just be aware, for patients who are on these medications, especially things like phenytoin, especially another drug called lamotrigine a little bit later on, new rashes should be really, should kind of raise red flags for you and the patient. Because it could be a risk for something called Stevens-Johnson syndrome. If you don't recall, I think I mentioned it back in pharmacodynamics probably, but it could cause this sort of, basically like this skin breakdown causes the skin sloughing to start to occur. They develop rashes and blisters, and it can be fatal because basically they're like causing this huge denuding of a lot of their skin, and it requires immediate discontinuation of the drug and immediate presentation to the hospital for further care. It's treatable if you catch it early, but if not caught early and allows it to progress on its own, then very likely to lead to patient demise, unfortunately. So Stevens-Johnson's a big thing we are concerned with. Again, here's just that first order versus the order kinetics we're talking about. Remember, normally most drugs are going to be at the first order kinetics here, where everything metabolizes quite normally. But if the levels are too high, it flips over to that zero order and it just goes slow as a rock. It takes forever for the levels to come down. And really, there's not a whole lot you can do about that in a lot of cases there. So that's why we want to make sure we don't overdo it with these patients. And that's why we follow levels for these patients. Phenytoin is one where we actually do therapeutic drug monitoring for to make sure that they don't get too high of a level, right? Now, I will tell you, back in the day when I first started teaching you guys, or PA students in general, I actually had people memorize levels for these drugs. I don't do that anymore. So hopefully, I hope you can appreciate that because of the fact that you can look this stuff up, right? But it's good to know that why do we do the therapeutic drug monitoring? Well, it's because of the kinetic issues we run into and can lead you to too many side effects, right? There's too much other important information here I want you to get than just memorizing a number. You can look numbers up later on. So that's kind of one of the changes I've made over the years, just as an FYI. Anyway, also, when you think about some of these drugs with longer half-lives, remember that if a patient's having a seizure right now, you probably want that drug to get up to an effective level very quickly. So how do you do that if a drug has a long half-life and it takes a while to get to steady state? Well, as you recall, we do loading doses. Here's another example here where we can do a loading dose to get patients up to steady state quickly to stop a seizure, and then you can put them on their maintenance dose and to kind of keep them at that level. And if you were to get levels, this is what we'd look at. So the total phenytoin level, which measures everything in the blood, is normally around 10 to 20 micrograms per ml. And if you recall, I mentioned it's 90% protein bound. So sometimes what we'll do, especially with patients with hypoalbuminemia, so low levels of albumin, we'll do a free level, and that should be around 1 to 2. So 1/10 of the total level there. If this is in I'll give you an example. You could have someone who has a level of 15, for instance, or 15 total level, and they're having all these side effects of dizzy, and they're having falls at home and all these things. You're like, what's going on? They have a therapeutic level. Well, then you go ahead and get a free level and realize that it's 2.5. You'd expect it to be 1.5, but then you go do an albumin level and realize the albumin level is low. Or maybe there's a drug interaction that was kicking the phenytoin off of the protein, and now the free level is 2.5. That would be indicating to you, okay, something's going on here. The free level is not 10% of the total, so there's some sort of interaction happening here. And then you can do further investigation. So that's why we do free levels. For a long time, most places couldn't do free levels, and so we had to really just rely on totals. It was more expensive then, so nowadays it's a little bit more available to you. Okay. Anyway, as I mentioned, the protein binding around 90% or so. People who might have issues with this include things like renal failure, where you can build up a product that may displace it from the protein. Critical care patients just being critically ill sometimes leads to lower levels of proteins. And then multiple antiepileptic drugs that could interact and kick each other off of the proteins can lead to those issues. So kind of the common things I would think about and maybe want to do a little bit more investigation to a free level than just look at a total level and kind of take it at face value. So if that makes sense. So phenytoin itself is kind of interesting because it does not like to go into solution. It's very insoluble in a lot of cases, which is bad if you need to give it IV, because most medications you think about, okay, well, I can give this orally, pretty good dose, pretty good route of administration. Well, if your patient's having a seizure right now, they're not going to be swallowing anything, right? Especially if they're going to be an aspiration risk because they're actively seizing. So we need a way to give drugs parenterally, right? So either IM or IV administration. Well, phenytoin, because it doesn't go into solution very well, we have to modify the solution that it's in to make it more soluble. That means getting up to a pH of like 10 to 11. Very basic compared to what our normal serum pH is. We also have to put in things like ethanol. We have to put in things like propylene glycol, things like that to get it into solution. What that means is it's very, very irritating to the veins. And also means that if a patient has an extravasation, it can cause significant tissue necrosis. If you recall, we talked about extravasation when we talked about the chemotherapy drugs, things like doxorubicin or vincristine. If they go outside of the vein into the surrounding tissue, they can wreak havoc. And here's an example of a patient developing tissue necrosis called purple glove syndrome when they've had significant tissue injury related to phenytoin extravasation. How do we try to get around that? Well, we try to make sure we're using deep veins, as deep a vein as possible. Imagine this patient was probably getting it in the hand, not a very deep vein at all. or central administration. If you get right into the vena cava, that would also be preferred there. So we don't like doing this IV. We don't like doing this IM. It's not even really, you can give it IM because, again, the tissue irritation is not great. So what do we do? Well, we came up with a more water-soluble version of it. So let's just pop a phosphate group on there, and you increase the water solubility pretty greatly. So this is where we get the drug phosphenytoin. So 9 times out of 10, if you're giving IV phenytoin, it should be phosphenytoin. Or in this case, you can even give IM if you want. Because of the water solubility, it's less painful, it causes less issues with phlebitis, and you may see it dosed as PE. This just stands for phenytoin equivalents. Just know that 100 milligrams PE of phosphenytoin is 100 milligrams of phenytoin. You don't have to worry about doing any conversions. 100 milligrams, 100 milligrams, no problem there. But the benefit here is that you have less issues of administering, especially like with little kids. If you imagine trying to give, like, a 2-year-old with very small, delicate veins, phenytoin, not a great situation. Phosphenytoin, though, no problem there, right? Less issues, I should say. But we've had issues too where like phosphenytoin actually went on shortage because there's an issue not with getting enough drug, but the actual vial that the phosphenytoin came in started like shedding like glass particles into the drug, right? So even little things like manufacturing issues can run into play, and we had to administer phenytoin to some kids, and it was not ideal, but sometimes you gotta do what you gotta do. But just know phosphenytoin is a water-soluble prodrug. Once it's in the body, it pops off that phosphate group, and then now you have phenytoin. You're good to go again. Okay, so switching gears, next we have carbamazepine or Tegretol. This is another sodium channel blocker. One of the things you're going to find too, and this will become more important when we get into the behavioral health medications, is we're going to see that there's a lot of crossover between antiepileptic drugs and our drugs used for bipolar disorder. A lot of these agents here, as they are suppressing hyperexcitability of the neurons, they also treat the manic symptoms of bipolar disorder. We call them mood stabilizers. And so this is where we're going to see the first one here of carbamazepine being used often for bipolar patients. Jackson's saying, I feel like I've seen filters on dilantin drips. Does the phos group increase the chance to precipitate? No, if anything, the phosphenytoin helps to decrease the chance for precipitation because it's more water soluble. Filters on a dilantin drip may be due to any kind of precipitate. Really just depends on the formulation too that you run into. So you may see different recommendations on that. But yeah, filters can be used to help keep any kind of particulate matter from being passed on to the patient and causing issues there. It's a good question. Someone has some questions. They said, since phenytoin is mixed with ethanol, would you want to avoid it in recovered alcoholics? That's a good question. Chances are it's such a small amount of ethanol that it's not going to lead to any sort of significant, issues with those patients who may have alcoholic use disorders. If anything, these drugs are going to be sort of sedating anyway, so it would be difficult to tell if any of the ethanol is actually causing any issues or not, because someone who got a really big dose of phenytoin might kind of look drunk anyway. But no, I would not have that being a huge concern for those patients there. It's a relatively small amount. The volumes you're giving are small anyway. That's a good question. Someone said, why or when would you recommend getting a free level on a patient all the time, or when they have side effects or liver issues? Good question. It depends. All right, back to, I'm just kidding. For most run-of-the-mill patients, especially if you've gotten them to they've been on it for a while now, you're just doing a level just to check to make sure no kinetic changes have happened. If they're not having any side effects, the total level is probably fine. It's probably reasonable to get. If you are suspecting they're having side effects, due to too high level of medications, and they had a normal total level. If you thought that it may have some kind of altered binding kinetics due to critical illness, renal failure, liver issues, hypoalbuminemia, any of those things that kind of make you think, wait, I don't know if this total level is going to be all that accurate, then you go ahead and get that free level. So if something is making your spider sense tingle, then go ahead and just get a free level. Especially nowadays, it's probably a little bit more available. It's more expensive, right? And you always want to think about being cost effective when ordering medication or ordering anything for your patient. But that would be a case where I just want to say, yeah, let me go ahead and just check a free level just to be sure that nothing else is going on there. You can identify a lot of problems like that. Right? Good questions. Like, you guys have very thought-provoking questions. I think you guys are really having a good mindset for getting ready to think clinically when you're out there on rotation. So good questions. Keep those good questions coming, especially for your preceptors. They will certainly appreciate that. Okay. Anyway, so getting back to carbamazepine, as I mentioned, you'll probably see it much more often used as a mood stabilizer for bipolar patients than you will as an antiepileptic necessarily. Just depends. And this is another one that has a lot of induction of CYP enzyme. So you're already seeing a lot of drug interactions are going to be prevalent with the antiepileptic drugs. So CYP3A4, 2C9, 2C19, all are going to be induced. They're going to be lowering levels of other drugs that are metabolized via those enzymes. So, for instance, with like warfarin, if you had someone who was on a therapeutic level of warfarin, their INR was 2.5, and then you put them on carbamazepine, you'd expect that INR to go down because you are metabolizing more of that warfarin. It's not around to sit there and do its thing, so INR comes back down closer to 1, right? Just as an example. Side effects are going to be pretty similar to Phenytoin too in terms of like mental status changes, depressed mental status, lethargy, dizziness, all of that. Very, very similar in terms of the adverse effects. Again, for patients who got a big dose of an antiepileptic recently, they may look very similar to alcohol. And because again, they're all really doing the same thing to suppress hyperexcitability of those neurons there, right? Carbamazepine also undergoes what we call autoinduction of its own metabolism, meaning that it speeds up its own metabolism as it's introduced and upregulates those enzymes. And I'll show you a way we can actually get around that. And so sometimes when you see dosing strategies that say, we'll dose this during week 1, and then you increase the dose for week 2, 3, and 4, part of it may be due to things like this. And so I'll show you that in just a second here. This is another one you want to watch for the LFTs because it can be kind of rough on the liver. So LFTs are probably going to be checked on the majority of these drugs. So just consider checking them at baseline and then follow up after probably 4 or 6 weeks of being on it. You want to make sure you're going to be catching any of those big rises in LFTs. Typically, if LFTs start to rise more than like 3 times the upper limit of normal, that's where you want to start to get really concerned and consider switching them off to something else most likely, right? Now, hyponatremia is also interesting. There's a condition that we'll get into in the renal section, but I'll introduce it here. It's called the Syndrome of Inappropriate Antidiuretic Hormone, or SIADH. Some of you may have heard of this before. Basically, if you recall, ADH, antidiuretic hormone, is something that causes us to hold on to more water because we're antidiuretic, or anti-urination hormone. So it's going to hold on to water. It also increases our thirst response. We're going to want to seek out water and drink more heavily, right? What that does is it dilutes out the sodium that's sitting there in the blood and can cause hyponatremia. So this is another thing where if I was looking at the monitoring parameters for carbamazepine, I would say, well, I want to monitor the sodium as well because the chances are they could actually cause hyponatremia due to this SIADH. This is more clinically important for a cousin of carbamazepine called Oxcarbazepine. I'll get into that in just a moment here. And then to some degree, it can have a little bit of bone marrow suppression, so you would want to monitor their CBCs as well. Look for things like platelet suppression, look for things like leukopenia, things like that. Here's what it would look like when you're doing the titration here, where you can see that as the autoinduction occurs, as it increases its own metabolism, you have to overcome that by giving bigger and bigger drugs, and then it eventually levels out. And so by giving this, say 15 to 20 mg per kilo per day, they can establish a good therapeutic range. You can see here, between 4 to 12 is what we're normally shooting for. Again, am I going to ask you the specific dosing? No. Am I going to ask you specific levels? No. But consider, I could ask questions where I give you a level, I tell you what the therapeutic range is, and then say the patient's presenting like this, what do you want to do about it? Those are more the questions I might ask that have to do with drug levels, right? So again, you can look up levels. I can give you the level, but or normal levels, but I want you to be able to interpret them and then act on those things. That's the application process that we're kind of getting to at this point in the semester, okay? And maybe it'll give you some examples later on if you guys are interested. Anyway, so oxcarbazepine, as I mentioned, trileptal is another one you'll see used as a mood stabilizer pretty frequently. This is also going to be kind of a cousin of carbamazepine. It has less side effects, so less like not as many pharmacokinetic interactions because it doesn't really induce as many enzymes. No autoinduction. The only thing that's really different here, besides a better side effect profile, is it's more likely to cause SIADH, more likely to cause hyponatremia. So you absolutely do need to be checking sodium levels with oxcarbazepine to make sure they're not going to run into any issues. And you say, well, what's the problem with having low sodium levels? Well, low sodium levels, guess what? They can cause seizures, right? So the question is, okay, well, this patient is seizing. Is it because their drug's not working? Or is it working too well and now it's causing SIADH and now they're having hyponatremic seizures? Treatment of which is going to be very different than typical seizures. As in case of hyponatremia, guess what you do? Give more sodium. So we'll get into that more so in the renal section coming up later in the semester, but definitely something I want you to think about with oxcarbazepine. Next up, we have a very common drug you're going to run into, very frequently used, valproic acid. You'll hear it called Depakote, but there's a lot of dosage forms: Depakine, Depakon. If it starts with a Depa something, it's going to be probably a valproic acid derivative. Okay, valproic acid is pretty interesting here because this is the first one we're running into that has a several different mechanisms that you're going to be seeing here. So not only does it block sodium channels, but it also helps to inhibit some calcium channels. It also helps to enhance the activity of GABA, right? So by working through multiple mechanisms, you can see how it may have some additional clinical benefit of helping to prevent these seizures here. It also is fairly well tolerated for the most part by most patients. And again, this is another extremely common one you'll see for bipolar disorder. Used as a mood stabilizer. You see this used. I see it actually more often than in seizures for actual behavioral health issues besides bipolar disorder, but things like I've seen it in some cases like an oppositional defiant disorder, just to like kind of chill some of these kids out a little bit. Have certainly been used. So you'll see a lot of EPA, which is how it's frequently abbreviated out there. In terms of side effects, again, sedation, pretty common, ataxia, that all makes good sense based off of what we've seen with the other anti-epileptic medications. Some unique things I would look out for include a patient who develops pancreatitis. You want to at least be able to rule this out by looking at their medication profile. So that's kind of a unique thing to VPA. Definitely look at their liver functions, both at baseline and follow-up, to make sure nothing's going on there. And then you can monitor their platelets as well. It can be a little bit of suppression of the bone marrow from that standpoint there. So very good drug other than that. This is another one we'll do certainly some therapeutic monitoring on, but the range here, because it's so well tolerated, could be pretty wide. So for instance, for seizures, maybe you're shooting for 50 to 100 mics per ml. For bipolar disorder, maybe I'm looking for, say, like 150 to 200 in some cases, right? Just really depends. And interestingly enough, in considering overdoses, which patients with bipolar disorder certainly are at risk for overdose based off of them going from a depressive phase into a manic phase, and all of a sudden it's energy and they act on these thoughts of self-harm. So I've definitely seen plenty of overdoses for some of these drugs used as mood stabilizers, and the tolerability of valproic acid is much better than you'll see with some of the other ones. So for instance, with carbamazepine, typical levels like 4 to 12. Once you start to get like a level of like 20, you start to worry about risk of like things like cardiac dysrhythmias and further seizures, things like that. With valproic acid, I've seen patients get up to levels of like 400 or 500, and they do just fine. I've seen some cases up to like 7, almost 1,000 mics per ml, and occasionally may need to be intubated, but they still tolerate it fairly well and are able to metabolize it off and kind of get back to their baseline. So relatively safe from that standpoint. One other thing to note too is teratogenesis. Okay, so this means that it's going to be causing some issues here in terms of fetal development, and actually this can cause neural tube defects, right? So just like folic acid deficiency can do this, this can also cause some of those neural tube defects there. This can be challenged too. So if you, and again, not to get too much into the behavioral talk, but dealing with bipolar patients, one of the things they do is they kind of have some impulsive activities, or they may do gambling, they may do drugs, or they may have promiscuous sex, for instance, and get pregnant. Well, if you have someone who is on valproic acid who gets pregnant, you don't, it's not like the second you get pregnant, some angel comes down from on high and shows you a light, says, hey, guess what, you're pregnant. It may take months before people find out. In meantime, they're on this VPA the whole time and the damage is done, right? So this is why it's really important for patients, or even if you have like teenagers, for instance, who had seizure disorders on VPA, making sure that they're on appropriate contraceptives to ensure that they're not going to accidentally get pregnant and could have negative effects on the fetus. So just something to consider. This is kind of a unique thing so far we've seen for valproic acid. Okay. So next, switching gears, this is like a go-to set of drugs for acute seizures. And this is probably going to be the first line therapy for most acute seizures that are happening like right in front of you, right? Or the benzodiazepines. You're going to see these drugs used for a lot of other things as well. We use them in surgery all the time, especially through anesthesia. We use this as a treatment for anxiety and panic attacks. You're going to see a lot of use of benzodiazepines that are out there. Again, how are these working? Well, basically they bind to a different site on the GABA A channel, and they allow for GABA to bind more readily. They cause a conformational change and allows for GABA to bind easier, and so that way it will then open up and allow chloride to flow in and hyperpolarize the neurons, right? We have a lot of examples here. I will give you even more examples when we talk about their use for anxiety, but I want to focus on the ones that are used most frequently for seizure disorders. Okay, you can always tell if it's a benzodiazepine because it will end with the suffix "pam." So diazepam, lorazepam, midazolam is kind of an exception. But then you have things like clonazepam. And then here's actually a newer one called Onfi or clobazam. But generally, if they end with the am, most of the time it's PAM on the end, then you'll pretty well know it's a benzodiazepine. Except for chlordiazepoxide, I guess that's another exception there. But there's always exception to rules. Anyway, so again, when you're thinking about people who are having active seizures, you want to think about ways to get it into the patient. So for instance, for diazepam, it frequently came as what we call diastat. So just like someone who has a history of anaphylaxis, they would get an EpiPen to take with them in case they have exposure to an allergen. For patients who have seizure disorders, we would give them some sort of rescue therapy if they have an acute seizure. Now, obviously, they cannot give it to themselves because they're having a seizure, so their mental status is not such that they could do that. However, their caregivers or people around them, family members, could administer this to them. And again, you don't want to give anything orally to someone who's actively seizing, and so for a long time, we used diazepam rectal gel. Well, Diastat was the brand name for that. And so basically, if you had someone who's having a seizure, you could undo their pants and insert this rectally, and that allows for rectal administration, rectal absorption of the diazepam, and hopefully will then cause cessation of the seizure, right? So pretty good from that standpoint. However, it's a little bit cumbersome, so to speak. You know, if someone who's having tonic-clonic seizures, you know, they getting their pants undone and inserting this, it's a whole ordeal, right? And so, especially unless you've been, you know, trained to do it or have done it before, it can be a little bit harrowing. Especially if you think about someone who, like, if their child is having a seizure, like, you know, it's kind of a scary situation, right? Nowadays, it's starting to sort of switch gears a little bit, and most of our neurologists are actually recommending midazolam or Versed, which can be given either orally, IV, which is probably the more common thing you'll see, or the really neat way to do this is intranasal midazolam. So basically what we can do is we can draw up the IV form. We can put on something called an atomizer, which is basically, it's not named after me, but it's an atomizer, which basically forms a really fine mist as you shoot the drug through it. And that allows it to coat the nasal mucosa and allow for easy absorption of the drug. Bioavailability is not as good as IV, obviously, but it still works pretty well. And again, it doesn't involve having to like get their pants off and all of that. So intranasal Versed is starting to become more common for sort of outpatient use for acute seizures here. Isabel's saying, for those with seizure detection dogs, can they prevent or pre-treat if the dog alerts them they're about to have a seizure? That's a good question. I don't know. I've not talked to any neurologists about that specifically, but that would be a good question if you ever get a hold of one. Maybe Professor Kaplan knows. I'm not sure, but that could be a good thought that where they're like, okay, well, if you have your dog, you know, it says, hey, you're gonna have a seizure, maybe go ahead and take this beforehand, or maybe they could have like an oral dosage form that they could take right away to maybe stave off a seizure. So that's interesting. I'd not actually thought about that before, but that's a pretty cool thing you could do. Whoa, I'm getting some kind of weird thing here. Anyway, so there's that. You know, lorazepam, this is probably the most common one that we run into in terms of use in the hospital. We use this all the time for acute treatment of seizures. Any of them are going to work just as well for one another. They'll do the same thing. Keep in mind, these are also controlled substances. Okay, I'll talk much more about controlled substances in the ortho section. We get into pain management, but we've already talked about this a little bit in the behavioral or the pharmacodynamic course. But remember, there's different levels of control. C1s mean that there's no medical use for it. It's a felony to have possession of it. You know, marijuana still falls into a C1 federally. C2 having kind of the most tight control, down through C5 having the least tight control. These are C4, which means that they're explosive. Just kidding, not really. But it does mean that there is a risk for abuse and risk for diversion. So that's why they go ahead and say, okay, we're going to control this. That means that they have all those regulations on the prescription. So they're only good for 6 months. You can only get so much. So again, that can be a little bit more cumbersome than just getting a regular non-controlled script like of Biproic Acid, Carbamazepine, etc. So that is one notable difference with the benzos versus other things. Now, side effect profile wise, these are going to be very sedating. And so these are basically doing the same thing that ethanol does roughly, is this causing these GABA channels to open up. And so they're much more sedating than what you might see for than something like, Phenytoin or Carbamazepine, right? So, if like kids need to go to school, for instance, and pay attention in class, like this might not be the best set of drugs to use for maintenance therapy. but these are really good for acute treatment of seizures. Now, some people will be on these around the clock. It just depends. Like clonazepam, you'll see used for pediatric seizures around the clock, but that really depends on the patient. Sometimes them being a little sedate is okay because maybe, you know, their mental status around the clock isn't such that they're going to be needing to worry about things like going to school and whatnot. So it really just depends on the individual patient situation. But overall, these are very sedating. These will have very similar effects as ethanol in terms of kind of the clinical effects you might actually see with them, especially at really big doses. Someone's asking, can you pre-treat seizures in general? Generally, no. It's hard to tell if they're going to... some patients have auras prior to seizures actually happening, but you don't necessarily pre-treat. The main thing would be if they're on maintenance therapy, that is your pre-treatment, right? So if they're on phenytoin and they're kept at a level between 10 to 20 mics per ml, presumably that's preventing a lot of the seizures that are happening. So there's not really a way to necessarily pre-treat in a lot of cases. Maybe the therapy dog would be one way to do that. Otherwise, it can be difficult to do that necessarily. So there may be some fringe cases. Someone says, doesn't Versed come in IM form? Also, yeah, you can use the IM. It's the same. So when I say parenteral dosage form, that's the same dosage form that can be used IV or IM. It's just a matter of where you're injecting it. The actual drug itself has not changed much. And then someone said, can PAs prescribe benzos? Yes, you do have the ability to write for controlled substances, but remember you have to get your DEA license. There are also some other restrictions on that. I will talk about that extensively in some of the law changes that have occurred in the pain management section coming up. That's where we get into all the narcotics and whatnot. But the short answer is yes, but there are obviously stipulations like getting DEA acts or get your DEA license and all of that. So it's certainly something that took a while for Florida to get to, but as with most things, Florida is pretty late to the game for a lot of these changes. Anyway, let's see here. So big things with the benzos you're going to find is that they can have a lot of individual differences amongst one another. Some of them undergo total renal elimination. Some of them require hepatic metabolism. Some of them are fat soluble versus some are water soluble. That can make a difference in terms of how quickly it works. To give you to treat the seizures, they may have a little bit faster onset, but they also come out more quickly. I think my stream is hitching up here. Oh my goodness, I'm frozen. Okay, I'm starting to come back now. Anyway, so, you'll find that fat soluble things can cross the blood-brain barrier more easily. They get in there, it can treat the seizure, but they also leave more easily. So maybe you don't have a lot of seizure protection over the course of, say, 30 minutes to an hour or so. Versus Ativan or lorazepam is more water soluble. It may take a little bit longer to cross the blood-brain barrier. Once it's there, it sticks around for longer. And so that may be a case where you get better, maybe a little bit longer in terms of initial onset, but it sticks around for longer. Can maybe prevent recurrence of seizure down the line, maybe by a couple hours. So some of that may make a difference in terms of what you're deciding to pick. We'll cover this a lot more in detail in the behavioral health section. We'll get into all the other examples you have for that as well. But as I mentioned, these are go-to for acute seizures, whether it's the rectal, intranasal, IM route. If you have an IV established, that's great. But a lot of times if you have a patient actively seizing, that can be difficult to get an IV established. Maybe it could be a good opportunity for an IO, who knows? And then, as I mentioned, the oral agents you take around the clock would be better for the prevention of seizures. Maybe not like a prophylactic, but overall maintenance and prevention of those seizures there. And sedation is going to be the most common ADR here. So just like you would see with someone ingesting alcohol, sedation, ataxia, things like that are going to be most common here. Again, another thing to be careful of is do not mix this with other CNS depressants. So if you mix this with other CNS depressants, especially things that also potentiate GABA, like for instance ethanol, you will find a lot of synergy there. And so what's kind of funny is one of the things I was always taught in fellowship was that benzodiazepines are like super safe. And they said the only way to die from an actual benzodiazepine overdose when used by itself is if you got hit with the truck that was delivering it to you. Very safe, right? However, when you start to mix that, because again, respiratory depression is not going to be a really big concern. You might fall asleep, but you'll probably still keep breathing if you overdose on benzos. On the other hand, though, once you start to mix it with other CNS depressants like alcohol, like opioids, all that goes through, all that goes down the drain, and so it's much more likely to run into life-threatening respiratory depression. So again, be very careful mixing these. I actually, I talked to a girl one time who said that, oh yeah, like, in college, it was a really good way to save money. You just take a Xanax, and then I only need one drink for the night, and I'm good to go. So I save money at the bar. I was a little bit horrified, but I tried to, say, that's one way to do it. Yeah, that's true. So be very cautious. It's very easy to overdo things, and again, you may even find benzos are, could be one of the more common things used to see to spike drinks in order to, have some illegal activities happening too. So be very careful mixing these with any other CNS depressants. Yeah, try to keep a non-judgmental reaction, but sometimes internally the screaming can make it out. But I try to keep it non-judgmental. 5D chess over a pit of sharks. Yes, that is a very apt analogy, I think. So next up, I want to get into the barbiturates. So if it ends with a barbital or some kind of barb in the name, then chances are it's going to be a barbiturate. That's going to be the class of drugs that this falls into. Phenobarbital is probably the most common one you're going to run into in order to treat seizures specifically, at least use, sort of for general maintenance. One time I had a patient actually come up when I was doing my rotations, and I was at a Publix for my community rotation, and I actually had a guy come up and he asked for a refill on his peanut butter balls, and it took me a long time before I could figure out he meant phenobarbital. So I was like, okay, well, that makes sense. Anyway, so maybe I could put phenobarbital in a peanut butter balls, and that would be like a really good product to sell, perhaps. Who knows? But anyway, so the big difference between these and benzos are, whereas benzos help GABA to work better, they help to open those channels once GABA binds. Phenobarbital just opens it directly, which means that it basically can have a much more sort of potent effect to cause those channels to open, chloride to flow in, and you hyperpolarize, causing the seizure to stop, right? That sounds great. But it also means you're also going to see a lot more adverse effects in terms of sedation, right? It can also more likely cause respiratory depression. And so overall safety-wise, it is less safe than you would see with something like a benzo, okay? Kaylee's saying, pain clinic I used to work in, used to call a patient on benzos, muscle relaxants, and opioids the terrible trifecta. So benzos, muscle relaxants, and opioids. I always called it oxysomanex. Basically, they'd come in overdosed on oxycodone, Soma, which is a muscle relaxant, and Xanax. It is a nasty trifecta because they're very likely to need to be intubated because they cannot breathe on their own because they have so much CNS and respiratory depression going on. It is a very dangerous combination and unfortunately is way too frequently used. So I would be very cautious ever prescribing any combination of those three drugs. It's very, very playing with fire to a degree, okay? Someone said, I heard that there's a link between benzos and Alzheimer's. Do you know anything about that? I haven't looked into it specifically, but it does make a sense. If you imagine, memory loss as being something you can see with ethanol, right? Short-term memory loss. You could see how someone on benzos could sort of mimic the kind of the signs of Alzheimer's, right? So someone having memory impairment, you could see that certainly with people on benzos. I don't know about it specifically affecting maybe the incidence or onset of Alzheimer's, but that'd be an interesting question to answer. But yeah, maybe if you have any more info on that, that would be interesting to check out for sure. Or maybe that could be a good topic for your grad project, your research paper in the summer. So something to consider, right? Anonymous question asker. So phenobarbital, much more sedating than the benzos. So again, this is not going to be a good drug if people need to like go drive or they need to, and again, driving with seizures is a challenge anyway, but they need to go to school or if they need to do something attentive, this may be a challenge. But, if you have a neonatal seizure, if you have a neonate, they don't really need to be paying attention to much anything anyway. So phenobarbital is actually a really good drug. So this is actually the go-to drug for patients who are neonates having seizures. So that's a really good use for this drug here. And overall, though, for like more older patients, adolescents, adults, this will not be used very frequently. It will typically be as an add-on drug to multiple other AEDs that these patients happen to be on, okay? This is also a controlled substance. All the barbiturates are going to be controlled substances. So just something to note with that. Interestingly enough, I had one time during that same community rotation that a patient came up and they're getting phenobarbital, and something I'd never even like thought about, but it's like, well, like animals get seizures too, right? And so if you ever find someone is trying to get a prescription filled for their animal for phenobarbital, that's generally the drug they go with as well. So if like a dog has seizures, they frequently use phenobarbital pretty often. So anyway, as I may say, most often CNS depression is the most common side effect. Interestingly enough, some kids may have a paradoxical reaction, very similar to what you would see with like a Benadryl or other antihistamine, where they can have that kind of increased excitation. So just depends on the person there. And then again, this is another one that gets metabolized by 2C19, but it also induces 2C9, 3A4. Another reason why benzos are probably preferred to this is just a lack of the drug interactions you would see with that, which is problematic with the set of drugs here, right? And again, better for patients who are refractory. They failed other AEDs if they're in status, and I'll talk more about status epilepticus a little bit later on. But this is kind of like third, fourth line for that if kind of other drugs have been failing there. And again, this is another one you do therapeutic drug monitoring on, and the range though can vary greatly. I've seen some patients up to levels of like 60, 70, and they can still talk and have a conversation. Just like I am right now. So maybe even more coherent than I am on a general basis. But just be aware of that. And again, to some of the sedating effects, you will see tolerance, right? Just like with the benzos, you'll see that. But be very careful with benzos, with barbiturates, anything that potentiates GABA like this, that directly opens that channel or enhances the channel opening. Withdrawal can be potentially fatal. Withdrawal, you have to really watch out and make sure you're tapering patients off these drugs here. Benzos, barbiturates in particular, you want to be careful. Why is that? Well, the body gets used to having that extra GABA activity around, and at a point it gets to be that's just the baseline. It's just used to that. Well, if you start to withdraw these drugs immediately, those levels drop. Well, guess what happens to GABA activity? Well, GABA activity goes down, which means that now you have an imbalance between your brake pedal and the gas pedal. All of a sudden, your brake pedal is not working, and your foot is on the floor on the gas pedal. Seizures can happen. So that's why you see this with ethanol withdrawal, benzo withdrawal, barbiturate withdrawal. Seizures can be a common manifestation of that. And you do want to be careful because, again, how do you treat these patients who are having withdrawal seizures? Well, you give them back the drug, basically. You give them more benzos, and that generally fixes the problem. So just something to consider. Oh, someone asked, what exactly does AED stand for? Sorry if I didn't. I think I mentioned it yesterday, but it stands for anti-epileptic drug. If you ASD is anti-seizure drug, they'll kind of mean the same thing there. So if that makes a sense. All right. Another one you'll see occasionally is called pentobarbital. This is very similar in terms of mechanism and drug reactions. But if you ever need someone to go into what we call someone who's in refractory status epilepticus, sometimes we'll do this to what we call put them into a pentobarb coma. Where basically you just try to knock the patient out as hard as possible. You intubate them, obviously. You can still breathe for them, but just in order to make sure that seizure has completely stopped, right? Especially if it's, completely refractory to everything else, occasionally we'll do that. So when they say like a medically induced coma, that's basically what we're saying there. And in fact, I'm pretty sure, I'm trying to think, if you're looking at, if you ever look up the topic of, I think, what am I thinking of? If you do executions of people, drug-induced executions, lethal injection, that is the word I'm thinking of. Thank you for people who are probably shouting it at me at their computers. If you have lethal injection, actually one of the drugs they may give, they typically give a trifecta of drugs. They'll typically do some sort of sedative, which either a benzo or a barbiturate, maybe pentobarbital, to sedate the patient. Then they'll put them on a paralytic to stop them from breathing, and then they finally get potassium chloride and to stop the heart. So if you ever look into that, it's kind of interesting. Also kind of horrifying. There's a good Last Week Tonight with John Oliver where they talked about the lethal injection and just how scary it is. And there's a really bad pharmacist who's on that video as well, who I would not trust to lethally inject me by any means. Not that I would want that anyway. Anywho, someone said, which anti-seizure medication would be best for alcoholics with seizures? It's a good question. Remember, too, like alcohol itself is an anti-seizure drug to some degree, right? It helps to suppress those seizures from happening. Probably most likely what you would do, and especially if you're trying to like have someone wean off of alcohol is you would then replace it with a benzo most frequently. And you'll see that too a lot for patients who have to be admitted to the hospital. We said yesterday that you could, some places would actually carry alcohol to administer to these patients, so like a, beer, PO, QHS, for sleep or something like that. The Joint Commission really came down. If you're not familiar with the Joint Commission, they're the people that accredit all the hospitals out there. And if you lose Joint Commission accreditation, you are in hot water. So the Joint Commission came out and said, hey, this is a big safety issue. We need to get rid of all this stuff. And so we ended up switching over and only use benzos almost exclusively. So for patients who have to go to the ICU who were alcohol dependent, we will switch them over to something like Ativan. And we actually have scales that we can use. If you ever heard of like a CWA scale, for instance, it gauges how much level of withdrawal they're having, and based on that level, that score, we'll give them a dose of Ativan in order to help kind of ameliorate that. In terms of seizure medications, maybe replacement with, honestly, the best thing would be to try to wean them off the alcohol, right? To have them stop using it. That'd be ideal. But, mixing a benzo, if someone who's still currently using alcohol, is a dangerous thing. So, maybe use a Biproic Acid or Carbamazepine, something like that, would be reasonable there. So, again, that would be a tricky situation, and something I definitely want to confer with multiple people, like the neurologist and different people like that. Maybe a psychologist that are helping treat their alcoholism, all that kind of thing. So, interdisciplinary care is very important. Someone said, can benzos cause permanent short-term memory loss or only while the patient is on them? I don't know that it can necessarily cause permanent short-term memory loss. Maybe if you had some sort of anoxic event that caused some brain damage, you could lead to that. But more often than not, you have, just like with ethanol, you have sort of the brownouts and blackouts. Brownout meaning that you only have kind of partial recall of what happened while on the medication. Blackout meaning you have no recall of what happened while on the medication or substance. Hopefully none of you have experienced that, but needless to say, we could use that for our benefit too, right? So if we have someone who's going to surgery, and especially like say a child who is quite nervous or apprehensive about going to surgery, we can give them a dose of Versed beforehand or midazolam, and that will kind of induce what we call this kind of twilight anesthesia, where they'll have a very loose recollection or no recollection of kind of what happened before the surgery, and they'll just wake up and be like, oh, well, what happened? I thought I needed to go to surgery, and it's already over, basically. So we'll use that to our advantage in some cases there to help out with that short-term memory loss, because I don't necessarily need them to remember, them having all that pain and getting the IV started, all that kind of stuff. So sometimes that's a good thing we do. Again, good job asking a lot of questions. I really appreciate the engagement. It breaks it up for me a little bit, and it keeps me kind of on my toes thinking about this stuff. So I do appreciate that. Now, Felbamate's an interesting one. You're not going to see it used too frequently, but this is kind of an example of one that, like, you really, there's some drugs, the side effect profile is just so bad that you want to hold off unless they are absolutely refractory to everything else. And so this is a good example of one called Felbamate, which enhances GABA activity and actually inhibits NMDA activity. So that way you kind of have more GABA, less glutamate, which makes sense in terms of seizure management. But if you're looking at the side effect profile, things like aplastic anemia, hepatotoxicity, it's just one of those things like, hey, if nothing else is working, maybe use this. But even then, I'd be very hesitant to do so. So agent you may see occasionally, but not too often. Next up, we have ethosuximide or Zaratin. Now, this one, I always recall this. And when I was in school, I had this guy, he's a physician teaching our lecture on antiepileptics, and he always said, ethosuximide is the drug of choice for absence seizures. And he said it about 40 times in a row, I feel like. So that always sticks in my mind. Now I get to pass it off to you guys. But ethosuximide is just a pure calcium channel blocker, right? So last time we saw that was Biproic Acid, but Biproic Acid did a lot of other things. This one is just calcium channel blockade for those T-type calcium channels, and this is the drug of choice for absence seizures, right? So those kind of seizures where they kind of stop and then they come back into it. This is what it's going to be used for, right? So because the seizures are so different, it makes sense that, then you're like your general tonic-clonic seizures, it makes sense you'd have a different drug for that. So if you have someone who's absence seizures, or if you see someone who's on ethosuximide, you can kind of put those two and two together to kind of figure out what they're on it for, right? Pretty well tolerated for the most part, but again, you wouldn't use it for general seizures or other types of seizures because it's just not all that effective. Okay. All right, another couple set of drugs here. We have gabapentin and pregabalin. Now, here you would think, okay, well, it has GABA right there in the name. Obviously, it must act on the GABA receptors, right? Not really. It's more so that they're sort of structurally related to GABA, and that's kind of where they got their name from. They interact with calcium channels, and they can actually help to enhance GABA synthesis, but they don't act on the same receptors as GABA, as it turns out. So kind of a misnomer there with the name a little bit. So a little bit different mechanism. Anyway, these you're probably going to see these used more frequently for pain issues than you're going to see them for specifically seizures. These would never be used as first line for seizures, more so as an add-on. But you'll see this pretty frequently for a lot of neuropathic pain issues. Okay, so we'll see some of these antiepileptics may be beneficial from a neuropathic pain because it makes sense. Pain is generating at the nerves, so let's chill out those nerves a little bit. So like fibromyalgia, postherpetic neuralgias, anything like that, maybe diabetic neuropathies. This may be a set of drugs you see go to, and overall they're pretty well tolerated. A little bit of CNS depression, and you can see some people go like really high on these doses here. I've seen people on grams and grams of gabapentin before, tolerate it very well. Just depends. And interestingly enough, gabapentin itself is a non-controlled substance, but its cousin, pregabalin, which is actually more potent, so the dose is a lot lower, is considered a C5. So again, there's restrictions on being able to get access to it. It's a little more tightly controlled than gabapentin. And certainly I've definitely seen some people use this as a drug of abuse because it's easy enough to get a hold of. You could probably fake an interview well enough to say, hey, let me get some gabapentin, and someone will write it for you. And so certainly you can see this abused with other things like alcohol and opioids and so. Another one, this is actually a pretty interesting one. It's called lamotrigine or Lamictal. This one has a couple different mechanisms here, including blocking a sodium channel. Something new here is it blocks glutamate release. So that's kind of cool that it kind of prevents glutamate from actually causing any excitatory signals. And then it modulates some of those calcium channels. So it can kind of help to limit their activity to some degree. Now, this one I've seen used pretty often as a mood stabilizer. So you may see it used for bipolar disorder. And actually, a few times I've seen it used for more adult onset epilepsy, which is not as common. Most kids or most people will be diagnosed as kids if they have true blue epilepsy, but you see some patients as adults who get diagnosed. And this is actually a good drug for them to get because this causes a lot less sedation than you would see than a lot of the other ones. So like carbamazepine or phenytoin, this is a lot less sedation. So this is good for people that like need to go to work and need to be able to be attentive at work in order to do their job, not like fall asleep at their keyboard or something like that, which if you did so already, I'm going to say, wake up. I'm just kidding. Anyway, a couple of drug interactions, especially if this is added on to some other medications. So for instance, its metabolism is inhibited with valproic acid. Okay, so if I'm adding this onto valproic acid, I actually need to lower my Lamictal dose versus it gets induced if they're on carbamazepine or phenytoin. So I would actually need to give a bigger dose. So again, this is another case where you really want to look at their concomitant medications and making sure you're adjusting as appropriate to avoid any sort of significant interactions here. So just something to keep in mind with that. Okay, rash is the primary adverse drug reaction of concern, and this is another really big one for Stevens-Johnson. So if someone is on Lamictal and they start to develop a rash, blisters, could be in the mouth, could be anywhere on the body, this is a warning sign to stop taking the drug and get checked out, right? Especially if they have any kind of like skin sloughing, anything like that, you need to go to ER to get evaluated because of the Stevens-Johnson that is there. It's probably more associated with this than anything else, but we'll find there's a whole several drugs that can cause this. But this is the one I always think about. It's probably like an easy board style question. If you rash and Lamictal, that's a red flag, okay? Otherwise, pretty well tolerated. Here's just an example of how you would dose these differently depending on if they're on an enzyme inducer versus an enzyme inhibitor. Some of this should be sort of intuitive based off what you understand about the terms inducing and inhibiting the enzymes. They're going to ask you how to dose these differently. Probably not. I don't care that you know specific doses. But, you know, if I said, hey, you're going to start up valproic acid, which is a Lamictal enzyme inhibitor, then you need to know, okay, I need to go up on my dose, right? So those kind of things I want you to be able to intuit based off of the kind of clinical situation. Whether you know the specific milligrams or not, I don't really care, right? Okay. Someone said, so is gabapentin a calcium channel inhibitor or is it its own category? It has, again, it's one of those things where some of these drugs are going to be sort of not so easily defined. You can't just put gabapentin into its own little box. It's its own drug, right? No, I'm just kidding. You're going to see it has, kind of a mix of activities. So it's difficult to put everything in just a one kind of neat, clean little box like we did with the antiarrhythmic drugs. So again, be able to know, okay, well, I know Biproic Acid has a kind of mix of different interaction or different mechanisms here versus gabapentin, which may be a little bit more specific to help GABA production and also block some of those calcium channels. So kind of in its own little category there. Okay, someone said, someone said, correct me if I'm wrong. I absolutely will. But if I remember correctly from our behavioral health certification and the substance use education, for someone on a hallucinogen or a stimulant, isn't a rescue med typically a benzo or a barbiturate? How would that work mechanism of action wise? It's a good question. Yeah, so if you have someone who is on a medication that is working as a stimulant, and that could be pretty wide, it could be amphetamines, it could be cocaine, it could be LSD, it could be DMT, could be lots of different things, right? There's a whole host of, it could be ketamine, it could be lots of different drugs out there that can cause sort of a stimulant sort of effects. Yes, to chill someone out, to calm them down. So I always think about classically, I think about the drug PCP or phencyclidine that had the nickname angel dust. Patients would come in and they are absolutely going out of their minds. They're fighting people. One of the things you'll find with some of these drugs that cause a dissociative sort of effect, kind of a mind out of body effect, is that they are still conscious and they do not feel pain. And so they become extremely strong because they have no kind of negative feedback to say, hey, you should stop doing what you're doing. You're hurting yourself. So there's been cases where patients are extremely violent and they need to be sedated, right? So typically we're going to give them a depressant in order to help bring them down. Whether that's going to be a benzo, it could be another drug like propofol, which we'll get into in the surgery section later on, whether it be something like an antipsychotic drug like Haldol. There's a couple of different ways we can do that, but basically we're just trying to induce sedation, whether it be through GABA, whether it be through anticholinergic properties or some other mechanism. This is what we're trying to do just to calm them down and try to prevent them from being violent to themselves or others, basically. So it can be tough, though. It can be a big challenge. That's why you need security there. You need all your people there to make sure that the patient and everyone else is being safe. I'm glad you appreciate the jokes today. I'm glad it's making the lecture a little more fun for you. Someone said, how soon will a rash or Stevens-Johnson syndrome show up after starting a drug like Lamictal? It depends. I don't necessarily see it as like a first dose sort of interaction, but sometimes you can see it in the first couple of weeks to even months that they might be on it, right? It could be a delayed reaction that they would run into that. So that's why, again, you're educating them, say like, hey, just because the first couple doses go okay, doesn't mean they might not have problems down the line. So it really just depends on that reaction the patient's having there. Okay. Very good. So next one is a particular favorite of mine. It's called levetiracetam or Keppra. This is a newer on the list of antiepileptics that have come out in the past couple of years here, relatively speaking. Actually, I remember I had like a Keppra notepad when I was in pharmacy school. So again, it's probably been 10 years since that. So it's generic now, but to me, it's still relatively new. And so anyway, this works by binding to this this kind of novel mechanism here, this novel receptor. It's called the SV2A protein, so synaptic vesicle protein, and it actually prevents neurotransmitter release. And one of those neurotransmitters being glutamate. So it actually works as kind of an anti-glutamate sort of drug here. And now it is quickly really becoming first line therapy. So whereas, we could dose, say we had a patient coming in for, say, into the peds ER, say it's a 6-year-old, first onset of seizures, they got 2 doses of Ativan, still seizing, what are we going to go to next? Traditionally, what we would go to after a benzo would be something like Phenytoin, right? However, due to the administration issues, due to side effects and stuff, nowadays we're now switching gears and going to Keppra. And in fact, for a lot of patients who are now newly diagnosed with epilepsy, I see a lot of our neurologists, at least especially in pediatrics, are now going to Keppra. So we see a lot of kids that are on that, kids that have epilepsy there. And so, you could also use it as adjunctive therapy. It's good as an add-on or just by itself. I see a lot of people using this as just monotherapy. It does undergo renal elimination, but even then, like the drug is so well tolerated that you can just give like just massive doses of the stuff. And even if they have poor kidney function, it's not really going to cause a lot of issues there. Not a ton of sedation, very few drug interactions. It's really, really well tolerated. So that's why we're seeing it used more and more frequently as kind of the go-to. Just to give you an example, like a typical daily dose for Keppra might be like 20 milligrams per kilogram per day. Some of these kids I see are neurologists, like who are coming into the ER seizing. They recommend we give like 50 milligrams per kilogram just like as a single dose, and they do totally fine with it, and it works great. So very, very good drug. However, there could be some kind of unique side effects. So in the clinical trials, they did find some increased aggression, especially in kids that are receiving this. So you could see some mood changes. Maybe they're a little more ornery than usual. Perhaps they're just, maybe being a little more aggressive. It could be related back to the Keppra. So that could be one thing you want to keep in mind. At least educate patients on, hey, if you notice any mood changes, let me know. Like it could be a problem where we need to maybe modify the dose a little bit or maybe switch out to a different drug depending on the situation. Okay, up next we have Topamax or Topiramate. This is one you'll probably see used a lot as prevention for migraines, and we'll talk about migraine prevention a little bit later on. Basically, this has a whole, again, kind of potpourri of different effects here, including blocking sodium channel, enhancing GABA, and it also antagonizes some of these glutamate channels, the amplikinate receptors there. Again, probably not by itself. You probably won't see it as monotherapy for seizures by any stretch of the imagination, but probably as an add-on in some cases there. And again, you probably see it more and more frequently as just like, migraine prevention than anything else nowadays. Again, for the most part, pretty well tolerated, but also in terms of anti-seizure activities, kind of timid, kind of meek in terms of its overall effects. Not as not as well, not as effective as some of the other ones like Tegretol or something like that. Interesting to note, though, it does have some carbonic anhydrase inhibitor effects, so that could lead to some of its anti-seizure activity. But that also could mean if you had someone who develops, say, like a metabolic acidosis, it could actually be related to that. Now, one of the things I put on there is I put a non-gap metabolic acidosis. I'm not sure if you're familiar with the term wide anion gap metabolic acidosis or WAGMA. I'm sure most of you heard of the term mud piles to determine why a patient might have a wide anion gap metabolic acidosis. This actually causes a non-gap metabolic acidosis, which means that the anion gap never actually forms because as you're peeing out bicarb, you actually hold on to chloride. And so the chloride levels are high enough that it kind of counteracts the loss in bicarbs. That's why you end up getting an anion gap, which is normal, even though the pH for the patient may be low. But I'm not going to get into the weeds on that. I'm probably not going to ask you that on the test by any means, but just be aware that could be something you see occasionally. All right, newer one you may run into includes lacosamide or Vimpat. This is, again, where we're starting to venture into novel mechanisms rather than what we were just doing with the traditional ones like Phenytoin and Biproic Acid. This one's actually working on this, what we call collapsin response mediator protein, or CRMP2. And actually can lead to decreased seizure activity by modifying these receptors and blocking them. So not only that, but also has some sodium channel blocking ability as well. So kind of neat that we're finding new mechanisms, new parts of the brain we didn't even know existed in order to help manage these seizures here. You could see some conduction issues in the heart occasionally, maybe like an increased PR interval, but frequently not going to be clinically all that too concerning. And it is a C5, so again, a controlled substance, so notable for that. And I see this used occasionally as add-on therapy for kids with seizures that maybe not well controlled just with one drug alone. Okay, so on the question here. It said, someone said, should we know the mechanism for all these drugs? You should be able to. You should be able to identify the mechanisms for the drugs for sure. Just like all the other lectures we've had, I at least expect you to know mechanisms and any kind of notable side effects and drug interactions and stuff like that. So that has not changed in my class at all. That is one thing I will not be softening my position on. You got to know mechanisms, right? Anyway, so those are the main sort of seizure drugs you're going to run into on a day-to-day basis for the most part. Okay. Now let's talk about status epilepticus a little bit, because this is like someone who's like actively having a seizure that is not breaking, or maybe they have a seizure that finishes, the patient goes in that post-ictal state, but now they're seizing again, right? That's kind of the definition for status epilepticus. How do we deal with that, right? First off, always ABC, right? Make sure the airway breathing and circulation are taken care of. Okay, so if you need to intubate the patient, for instance, right? I'm not going to get too much into that. We'll talk about intubations later as we get into the ER section of this class a little later on. But let's talk about the drug therapy for the seizures themselves. Typically, what you're going to go with right off the bat is going to be a benzodiazepine, right? For any acute seizure, benzos are always going to be your go-to to start with. So whether that be outside of the hospital or healthcare setting where the patient's using PR diazepam, or they're getting intranasal midazolam, or maybe EMS has arrived and they're receiving Ativan, or Ativan or Versed, either IM or IV, right? Those kind of your starter drugs you want to use. And again, you may be working in the ER. EMS brings this patient in, they're actively seizing. You want to find out what they've already gotten. Because if they've already gotten 2 or 3 doses of a benzo and they're still seizing, there's no point in you giving more of that benzo. You know it's not going to work, right? But they only got 1 dose and they're still seizing. Maybe give them another dose, okay? After 2 to 3 doses or so, you should have an idea of whether your benzos are going to be working. At that point, what's going to happen? What do you want to do next? Well, you have a few different options are going to be here. Traditional sort of logic would say, well, let's use something like a phenytoin or phosphenytoin, right? That was the traditional sort of second line drug. I will tell you nowadays, at least in pediatrics, where I mainly work, this maybe has changed on the adult side. I couldn't say necessarily from personal experience, but if that doesn't work, then you could go ahead and switch over to something like Keppra. Okay, so benzos first, all the ways, and then either something like a phenytoin or a Keppra would be a good second line sort of drug there. For our purposes, from my purposes from pediatrics, Keppra is always going to be the second line after the benzos are not effective. Then at that point, again, it becomes kind of question: what do you want to go to next? Well, phenobarb could be used here, right? We might try something like valproic acid. A lot of it now comes in because now at this point you're like 30 minutes an hour out from the patient initially presenting. You've probably already got neurology on the phone. You're probably already getting recommendations for them in terms of what they want to give. And so at that point, it's going to be kind of not out of your hands, but you're at least going to be kind of directed in what to use, because generally they'll have some preferences on what they like based on the type of patient and other issues like that. If you're down like 2 or 3 drugs and you're still not getting any response or still refractory, at this point is when we consider things like general anesthesia or some sort of medically induced coma to try to stop these seizures. This is where we could use a drug like propofol. I'll talk about that a lot later when we get into the surgical section, but pentobarb is another one we've used occasionally in order to try to get that seizure under control. So again, stepwise approach, always go with benzos first, and then your choices are kind of opened up from there, but usually either phenytoin or Keppra, or phosphenytoin or Keppra, either one of those. And then as you go down the line, start thinking about phenobarb, start thinking about valproic acid, and then just completely knock them out to try to stop that seizure. Now, occasionally I've run into issues where patients can develop what they call a non-convulsive status epilepticus, and that can be really tough, especially if the patient's got any kind of paralytics, because basically the patient will be still, but if you put an EEG on them, you'd actually find they're still actively seizing. That can be really difficult to manage. So having EEGs available will also be a big help for sure. Someone said, sorry if you already said this. Do we need to know what class they fall in as in a 4 or 5? I will not ask you specifically what class a drug falls into. I don't want you to know necessarily that a benzo is a C4 versus something like pregabalin's a C5. I'm not going to get that granular, but you should at least be aware of like what are the implications of the fact that it is a controlled substance, right? I'll probably get more into that in the ortho section. We talk about pain management, but just recall things like okay, well, you can only get a 6-month prescription for it. You couldn't do a full year, for instance, right? Something like that could be pertinent to your practice later on in life. Okay. I'm still a little confused about the metabolism of Lamictal and the drug-inducing inhibiting effects of valproic acid, carbamazepine, and phenytoin. Could you explain the differences in dosing and maintenance? Yes, I can. Go back to that question, or that slide. So when looking at this, if you have an enzyme inducer on board, right? So if I have something like phenytoin, something like carbamazepine that is inducing the enzymes, making more of them, it's going to metabolize Lamictal more easily, right? That means it's going to be metabolizing it quicker. You're going to get rid of it faster. So I have to up my dose in order to account for that, right? So as you can see, this dosing titration, you start out with 50 milligrams a day, then twice a day, and then maybe bulk it up between 300 and 800, right? That's for the inducer being on board. On the other hand, if I were to say have an enzyme inhibitor on board like valproic acid or VPA, you would want to go ahead and start a lower dose. In this case here, you're starting off on 25 every other day, right? So instead of taking it every single day, to do it every other day, right? And then you can eventually kind of build them up. And so notice the differences in the daily maintenance doses between 3 to 800 for an enzyme inducer. You get the same level as you would be if you were an enzyme inhibitor. You can only use 1 to 200 milligrams divided twice daily, right? So again, don't memorize these numbers, but just have an idea of what that means if they're on an enzyme inhibitor versus an inducer, and what that might do to your daily dosing, right? If you'd have to give more or less to overcome that. And I've seen cases where patients were not, this was not taken into account, and they got put on the standard dose of Lamictal while they're on Biproic Acid. And they actually got Stevens-Johnson's from that. Levels of Lamictal just jacked up high enough to where it actually induced Stevens-Johnson on them. So again, this is why I stress, always look the stuff up. If you're adding a new drug, just double check to make sure there's not going to be any interactions, especially if it's something you're not used to dealing with all the time, right? So I'll give you an example. Say you work in the ER, right? You deal with some seizure medications, but not stuff like Lamictal on a routine basis. But you have patients who are on Lamictal, and say they come in for a seizure, and you call the neurologist and say, go ahead and add on this drug. If you're not familiar with it, you should at least be looking it up to say, okay, well, let me look at their medication profile. Let me see if anything interacts here with this new drug that the doc mentioned. And you look and say, oh, there's a big interaction here. He didn't mention anything about that. You can call back and say, hey, what do you think about this? Should I modify the dose? And, maybe they already took that into account. Maybe they forgot about it. Who knows? But you did the due diligence. You checked it out just to make sure that you're not going to be causing additional harm or maybe ineffective therapy for your patient, okay? That's why I stress this stuff. And if you take nothing else away from my class, take away the fact that you need to look stuff up. Never take for granted that you know everything, okay? Oh my goodness, look at all these questions here. Okay. Which is good because we're at the end of class anyway. Okay, someone said, what is the follow-up criteria for a patient that comes in with status? Do they get sent home with maintenance AED therapy, or are they told to come back to the office periodically for brainwave monitoring? I feel like I need some brainwave monitoring. So someone with status is definitely going to get an ICU admission, especially if they're intubated, right? And if you're in status, you're definitely not protecting your airway. You're going to get intubated. So 10 times out of 10, they're going to go to the ICU until they've kind of been stabilized. They'll probably get put on some sort of maintenance AED drugs while in the hospital. If they've been downgraded from ICU to like the general med surg floor or something, they'll generally get put on some sort of maintenance therapy, make sure the patient's tolerating it. Then they'll get sent home to follow up at the neurologist's office, most likely. That's the general flow of how those things would probably go. In terms of how often do EEG monitoring, that would be up to the neurologist. That's not really in my wheelhouse necessarily, but I know it's a good tool to see if patients are seizing or not. If it took an hour for an ambulance to get to a seizing patient, do you still start with a benzo, or would you want to go to Phenytoin or other drugs? That's a good question. I remember one time I had a guy who called up. He's out fishing at a river and got bit by a water moccasin. And fortunately enough, he had a phone on him, so he went and called us up and said, hey, I got bit by his water moccasin, and it's starting to hurt real bad and looks like it's swelling. I said, okay, well, you need to call 911? He's like, well, I can walk back to my house and get transportation there. I was like, well, how long is it going to take you to do that? He's like, about 45 minutes. I said, yes, call 911. Oh, what are you doing? But anyway, so yes, if they have not gotten any therapy and they're still seizing, which if they're seizing after an hour, they're probably stopped breathing at some point. So they might be in a cardiac arrest at that point. But let's say, for instance, they were a known epileptic patient. They had a seizure. They went ahead and had a dose of intranasal Versed given, right? At that point, if EMS then arrives, the patient's still seizing, I'd probably still give a trial of a dose or two of benzos. So keep in mind, these drugs don't stick around forever, right? So at a certain point, you can kind of start over in terms of your dosing when it comes to things like, seizure drugs, for instance. So if it took a while, I would still consider giving a dose or two of benzos. Most of the time, EMS is going to be going off of a protocol they have anyway, which will probably include those benzos regardless of what the patient already got. And then once they get to you, you can kind of figure out, okay, what did they get? When did they get it? And then kind of where to go to from there. We have patients who will come in. If EMS has already given 2 or 3 doses of Ativan and they're still seizing, we're probably going to go ahead and switch over and give them something else. We might give them another dose of Ativan because it probably won't hurt, but we'll then get into something like Phenytoin or Keppra or something like that at that point. Yeah. Oh yeah, sometimes I switch into that voice to tell my stories because that's how most of my people talk. In the Jacksonville Center, we covered the whole Panhandle to like just north of Orlando, so we get a lot of that those types of people, as you might hear. Anywho, I'm also one of those type of people, so that's why I can switch into it very easily. Thank you so much for saying I'm a good professor. I really appreciate that. It's very nice of you. Anyway, I like talking about this stuff, so that's why I can joke around so much about it. Anyway, so that's good. We got through this slide here. I'm going to go ahead and cut it off at this point. So thank you all for joining me. I really appreciate you. And if you have any other questions, you can post them on the board. I'll get to them tomorrow, I think, when we meet again. Yeah, 12:30. So I will see you all there, and have a great day. I doubt I'm going to do an entire lecture in the southern accent, but perhaps if I tell enough stories, I'll get into it. Who knows? I don't think you guys want to hear me talk like that for a whole 2 hours. That'd be too much. All right, you guys have a great day. I'll see y'all later.